Hello, friends. Welcome to Creative Medicine. In this lecture, we will learn about
Now, so uh, these are the different things that we see in the oliguria. In the oliguria, you will see that there is increased intravascular volume overload, hyponatremia, hyperkalemia, and we see that there is hyperphosphatemia, hypocalcemia, hypermagnesemia, hyperuricemia. Then nutritional deficiencies. So all these are seen in the patients with uh, oliguric phase of renal failure. But now the issue is oliguric phase is gone. Now you will have to treat the patient. So when the patient is in oliguric phase, if the patient has volume overload, in the conditions of volume overload, you should give the patient salt and water restriction, because already there is volume overload. So it is not beneficial to give high salt and water to the patient. You should give diuretics to the patient, so that these diuretics will flush out the water which is intravascular volume overload which is present. You can do dialysis, can be done in these patients. Okay, then if the patient has relative hyponatremia, in relative hyponatremia we should ask the patient to restrict free water intake. Remember, this relative hyponatremia is not due to increased sodium in the body, it is due to the increased water in the body. So because there is relatively high volume of water when compared to the sodium, this has resulted in relative hyponatremia. So in this case we should restrict the free water intake in the patient. Then in hyperkalemia, you should restrict the dietary potassium intake also, because there is high potassium, so it is better to restrict the dietary potassium. Then you should eliminate the potassium supplements. Eliminate potassium by giving, you should not give potassium supplements. You should give potassium, sorry, you should stop the potassium supplements which were going on in the patient, if they were going on, or you should stop the potassium sparing diuretics should also be stopped. Then you should also stop potassium binding resins. Potassium binding ion exchange resins can be given. Okay, first you should stop potassium supplements and potassium sparing diuretics. Why? Because these potassium supplements and potassium sparing diuretics increases the potassium levels, so they should be stopped. Whereas potassium binding ion exchange resins are given. Why? Because they will bind to the potassium and cause excretion of the potassium. So as a result, they are given to the patient. Then for hyperkalemia, one important problem in hyperkalemia is arrhythmias. So in order to prevent the arrhythmias development, and for stabilizing the heart, we give calcium gluconate. Calcium gluconate is given for stabilizing the heart. It is given as 10 ml of 10% solution of calcium gluconate is given over 5 minutes. Then we can do dialysis is also advised in the patient for hyperkalemia. Then the next it is metabolic acidosis. For metabolic acidosis, if the patient has metabolic acidosis, we can give sodium bicarbonate which can counteract the acidosis, and then dialysis can be done. Then in hyperphosphatemia, if the patient has hyperphosphatemia, because there is increased phosphate levels in the blood, we should restrict the dietary phosphate intake should be restricted. Number one. Number two, you can give phosphate binding proteins. Phosphate binding agents can be given, like we can give calcium carbonate can be given to the patient, with aluminium hydroxide can also be given to the patient. So we can give calcium carbonate and aluminium hydroxide are also given to the patient for hyperphosphatemia. Then if the patient has hypocalcemia, you should give calcium carbonate, because calcium is less, we supplement with calcium carbonate. If the patient has hypermagnesemia, so magnesium is more, so it is better to discontinue magnesium containing antacids. So when you discontinue magnesium containing antacids, automatically the magnesium level comes to normal. Then in hyperuricemia, we should give allopurinol should be given to the patient for hyperuricemia. In nutritional deficiency, because there is nutritional deficiency, we should do restriction of dietary protein is done for about 0.6 kg per day. Sorry, 0.6 grams per kg per day should be given to the patient. You should restrict the dietary protein to about 0.6 grams per kg per day. And then you can also give carbohydrates should also be restricted. The carbohydrates should be restricted to as low as around 100 grams per day should be given to the patient. Now, in acute renal failure, we said there is hyperphosphatemia. We'll see next.
Thank you and thank you for watching.